Welcome to True Health Tuesdays, and the truth will set you free. How's that for a tagline? Today we're talking about shoulder pain, but not just shoulder pain, because when you do research, because it drives me crazy, we've got people from, literally all over the world coming in with shoulder issues. Not once have we referred them for shoulder surgery. And so either our methods are radically different, or the standard physical therapist, medical doctor are missing main causes, and they are. We're going to go over bursitis, rotator cuff problems, shoulder pain, everything. 3 factors they're missing. Now, I know I'm going to get a lot of hate mail on this one, but that's okay. Just know, because we're not going to talk too much about the anatomy, the physiology, the different pathologies. We're going to talk about the 3 missing factors that if these are paid attention to, it really doesn't matter what type of trauma your neck or your shoulder has occurred. Okay, neurogenic. Okay, this means the compromised nerve supply to the shoulder joint. The nerves that supply the shoulder come out of the neck, and you never see in the literature loss of curve or restoring the curve in the neck to restore the nerve supply. Huge, huge ignored cause. Vascular. You've got a heart here. Okay, poets have it here, but you got a heart here. No, you didn't get the poet on the heart on the sleeve. Okay. But the blood comes out and it comes underneath the clavicle, okay? And so if the head's forward, that can be compromised. Also, mechanical distortions. You've got all of these muscles holding this scapula onto the rib cage, and if the rib cage is distorted, you're going to alter motion. First, we're going to look at the neurogenic component. The brachial plexus, this is a plexus of nerves that comes out of the base of the neck. So if you've had a whiplash trauma, work at a desk, have some type of damage, and I'm talking years in the past, any type of cervical damage, particularly in the lower aspect of the cervical spine, you can damage the nerves that come here. And there's a number of what are called double crush injuries. You pinch it here, it leads to here. It leads to symptoms there. Have you ever heard of carpal tunnel syndrome? Yeah. Yeah. Anytime I say syndrome, think, holy shit, there's something wrong, okay? Because it means that people don't know what they're talking about. So carpal tunnel syndrome, they're not noticing that it's a double crush injury, compromising the nerve here, leading to a problem here. Shoulder and rotator cuff problems typically are double crush injuries, which means they begin at an impingement and it ends up with a problem in the rotator cuff. So you've got to look at the neurogenic component. Now, the rotator cuff muscles, if you've ever heard of this, I want to just cover anatomy a bit, because we've got 4 muscles. Their main job is to suck this humerus into this little tiny small cuff. Now, the hip joint has this full-on, cuff that goes in there, an acetabulum. That's why the hip has less range of motion than the shoulder. The shoulder just has a little tiny labrum that it fits in this little tiny glenoid fossa. But it has mainly 4 muscles. Their job, they do some work. They do a little abduction, they do some internal and external rotation, but their main job is to suck that humerus in that cuff. Now, when you're going to see what happens, the most commonly injured muscle is on the top of that. It's called the supraspinatus. And you might think, well, we've got these 4 muscles, and the supraspinatus is a little tiny thin one that goes around the top. However, if you have compromised blood supply or nerve supply, that's the most vulnerable. And this is something that you don't see in the literature, but you do see in practice after 20 or 30,000 people. Okay, so you're going to see this in actual practice, that the supraspinatus is the most involved, and compromised blood supply and nerve supply is it. Now, this patient here, you can see a bolt in the base of the neck, right in the center of where the brachial plexus comes out. I'm sorry, normal human necks, that x-ray on the left there, don't have screws in them. No, don't you dare say this guy was screwed. No, but what happened, and this is really common, okay, in surgeries. you're supposed to fuse the spine in a curve so there's room for the spinal cord. What's typical and very, very common is that it's fused backwards, okay, like this one. And sometimes we'll see 3, 4, even 5 segments fused in a reversal of the curve, which is, it's a bit more challenging to fix. Forward head carriage. And this, when you look at the literature, so many people are trying to fix rotator cuff injuries by working the muscle. And I've seen this time and time again. Now remember, those 4 muscles, the rotator cuff, are sucking this into this socket. Okay, and so many times people are loosening up the muscle, letting this muscle, and they're thinking that a muscle just spasms out on its own. It's from muscle spasms. However, we have conscious control of these. Muscles don't react on their own unless they're postural muscles. They're not under conscious control. So, I want you to own this one. See that picture on the right where the clavicle comes down and you're looking at the blood vessels underneath it. If those blood vessels or that head is forward, it literally does. It's called thoracic outlet syndrome. Okay, we know the outlet to the thorax is compromised and we know the head's forward, but no one's talking about curve restoration of the neck leading to a solution. You know, I mean, it's common sense when you look at this, but it's uncommon sense in the medical field. Here's the part that's the most important. And this is something that I was gonna say, raise your hand if you have a shoulder injury, but you couldn't raise it anyway. If you have a shoulder injury, raise somebody else's hand. Okay. Here's the bummer, okay? We've got those 4 muscles, the rotator cuff. They're holding this humerus in this little tiny cuff, okay? And it's a labrum. And if you've ever seen a labrum, it's kind of cool. It looks like soft Tupperware, okay, on a real live dead person. And well, yeah, I mean a real corpse, okay, that's in situ, and you can actually manipulate the stuff, and it's in a teaching thing, not just for partying. So you got this humerus in there, sucked in. Now what happens, you've got this massive deltoid going around the top that has all sorts of different features. It can flex it, extend it, abduct it. And so you have this huge deltoid over the top, always exerting a force to pull it up. Now, we know the most commonly injured muscle is the supraspinatus. Why? Because we've got compromised blood supply or compromised nerve supply to it. It's the most commonly injured. The challenge is there's some documentation to back it up, but so few people restore the curve in the neck that they're not even looking at it. Okay, so, but now realize, if that supraspinatus or one of those rotator cuff muscles is weakened, the humerus doesn't fall out of the socket, it falls up. Because think of this, the main job of that rotator cuff is to suck that humerus in the cuff. The supraspinatus gets weak, okay, and you've got this deltoid that's constantly pulling up, so it jams up. How do we know this? If you have a massive shoulder, rotator cuff problems, anything, you can carry a purse, you can carry groceries, you can do whatever you want here because it's pulling it down. But if you go like this, and everyone's nodding their head because it's like, oh man, I remember that. There's no, I ain't gonna live my arm that high. Okay, yeah, because what's happening? You've got this acromion process and it's called impingement syndrome because instead of functioning here, the top of that labrum, the top of that socket is distorted, and so you go up and bam, it jams it up there. And so that's called impingement syndrome. 2 most common injuries, okay, one's called a SLAP or superior labral tear from the anterior to posterior. The other one's a Bankart lesion. It's just telling you which side of that labrum that it's injured. You can see going up over that little white thing there is the long head of the biceps, the tendon. Now around, you can see how tendons cross joints. Isn't that interesting? Now you'd think that since that bicep tendon crosses the joint, that the more you move that tendon, okay, that there'd be a friction, right? Well, around each tendon, there's a bursa sac, and that bursa sac has bursa fluid in it. The bursa fluid is a superfiltrate of blood. when we look over there, the bursa sac, it's designed to cushion. So we have these bursa sacs around the tendons, in the joint, and they're there to cushion it. Now they're filled with a superfiltrate of blood. Has anyone ever heard of, how do you say inflammation in Latin? Say itis. You're so right. So now if the bursa sac doesn't have fluid in it and it starts to rub, it inflames. So that's called bursitis. Now a knowing thinking individual will say, well, man, if the bursa sacs are filled with fluid and fluid's a superfiltrate of blood, and you start to run it down and the fluid gets out of the bursa sac and it inflames, bursitis is from lack of blood flow to the joint. Simple, right? Logical? Okay, in barbarian world, they would take bursitis and put ice on it. Now, if you put ice on bursitis, okay, are you increasing blood flow or you're slowing it down? I know, I'm giving you that as a hint, so you can't really screw up, you know. Are you increasing it or slowing it down? No. Okay, so you are. So ice feels better on bursitis, but you're damaging the joint, you're not helping the problem. So this is why in chronic cases of bursitis, like in acute trauma, like you're throwing the baseball all day, or then ice is appropriate because you've damaged some tissue, you may have torn some blood vessels, that's appropriate. But in chronic terms like this, you put heat on that, heat on the extremity, never heat on the spine, but heat on the extremity, because that's going to rush blood to the area. It's going to increase synovial fluid, which is that filtrate of blood inside of the joint capsule, but it's also going to increase bursa fluid, so that makes sense. And somebody says, well, they gave me this look like, no heat on the spine. Okay, the reason is because in the spine, you've got muscles that run down either side of it. They're called postural muscles. Postural muscles you don't have conscious control over, so they increase in tone under nerve pressure. So if you put heat on the spine with those muscles in spasm, by gosh, those are protective. They're spasming out because of either proprioceptively, that there's the brain saying, man, tighten up that muscle, or there could be a lateral deviation that's going to tighten up the muscles. So there's a nerve issue or a nerve problem or a pinched nerve. That's going to spasm those out. It's kind of like, is the body smart or stupid? Smart. It's smart. It's really smart. Did you know that for every 1 inch the head's forward, the pressure on the discs double? And I just described how the blood vessels that supply the shoulder joint come out of this little tiny opening called the thoracic outlet. So if your head is massively forward, what do you think is going to happen to these muscles if that head goes forward? Just try it. Sit up nice and straight, put your head forward, and feel those muscles instantly get tight. You can't relax it. So these muscles are firing off to reposition it. That's why you don't want to put heat on the postural muscles, but for an extremity it makes sense because we're increasing blood pressure there. And this is how you trick a body, and this is what we'll do to a patient that's had chronic bursitis for forever. Okay, they come in and you know what they say? This is how they stand. Yeah, I've had physical therapy for years and my shoulder is still messed up. Yeah, I think they're missing the cervical component. I think you're probably missing a cervical. How can you tell? Damn brilliant. No, I mean, and plus too, normal humans stand like this with their thumbs. When that head goes forward, you start to see this internal rotation and everything else. And it's just fun at the malls now. You can see, you got shoulder issues, don't you? How did you know? So heat on there to restore blood flow, because this is neat. When you put heat on a joint and take it away, what color is the joint? Red. And this is what you're doing. Okay, see, the body senses at temperature differential. So it's trying to equalize the temperature of the joint. So it's rushing blood there. So you're artificially increasing the blood pressure in that area. So you're artificially increasing the bursa fluid production and the synovial fluid production. Bam! Okay, I know, but it just makes sense. It just makes sense. Now, this is the frustrating part because so few people restore curves in the neck, or no one's looking at it. Here's the Journal of Shoulder and Elbow Surgery. Subacromial impingement syndrome. When you hear syndrome, be scared. And the role of postural and muscle imbalances. Okay, when you look at this, subacromial, we've got this humerus stuck in that labrum. You've got the deltoid going over through it. If there's a superior displacement of that labrum, or if the rotator cuff, remember that supraspinatus? If any of those muscles that suck that in there get weak, does it fall down or up? It falls up. And that's called the subacromial impingement syndrome. Finally, we're starting to get to it, and this is 2005. Changes in upper body posture, colloquially termed forward head posture, I say that 3 times really fast, are considered to be an etiologic factor in the pathogenesis of subacromial impingement syndrome. The literature suggests that postural deviations associated with forward head posture follow distinct patterns involving an increase in the thoracic kyphosis angle, downwardly rotated anterior tilted protracted scapula, which in turn lead to increased compression of the subacromial space. It's kind of like I see forward head posture and I'm thinking, man, they're right on right. Oh, they totally missed it. Okay, they're saying, yeah, we found forward head posture and we know that that's going to start to, make the scapula, the kyphosis, everything round over because, this is the body posture if your head's chronically forward. But they're not taking it to the end. They think that this is from tight muscles or weak muscles. Okay, and that just doesn't make any sense. When we don't have conscious control of the muscles that run down either side of the spine. So when you're in this body posture, typically in the middle of the rib cage area, the thoracic area, if there's a compromised nerve, you're going to start to round over the shoulders because the nerves exit on the back half of the spinal cord. So this is a defensive posture from compromised discs. So that rounding over the shoulder is not from old age. Okay, you look at people 70 and 80 years old in Aboriginal cultures, you are not going to see this hunched over posture. You're seeing beautiful, healthy postures of hunter-gatherers. I mean, these people are in great shape. This is from lack of movement. When you look at these postures, understand that the disc has a horrible blood supply. In fact, the disc gets its nutrients through movement. If you alter movement, you alter the nutrients to that disc, and that bone comes down, compressing the disc, compressing the nerve. The body in its defense is going to start to round over the shoulders to open up those nerve holes. Does that make sense? Yeah. So what we're looking at here is a progressive lack of movement syndrome causing a body to distort in its own defense. Okay, this is not a positive thing, it's a defense mechanism. It's not something that we need to massage the muscles on, we need to correct the structure. And I love this. Surgery failures. So we've gone in there, we found out that the rotator cuff has got a damaged tendon. Let's go in there and sew it up. Anyone want to look for the cause? No, we're just going to sew it up. It's busted, we'll sew it up. So it kind of makes sense. Large rotator cuff repairs retore at a rate of 57%. And I love that. Okay, get this. Previous research has shown that 20 to 90% of rotator cuff repairs retear. Gee, that's in the ballpark. 20 to 90%. Yeah, I can get that. Marriages, 20 to 90% work out. Yeah, I mean, and then you go to look for documentation that supports this data, and it's virtually non-existent. However, and this is one of the things, you may have heard overuse syndrome. Okay, wait, did I just say overuse syndrome? Okay, overuse injuries, okay, which is what the overuse syndrome, overuse injuries, repetitive motion injuries, repetitive motion syndrome. Well, let me tell you, these things don't really exist. Boy, am I going to get some hate mail now. Okay, because if you're doing the same motion over and over, okay, you're a checker, you're working at something, okay, you're doing that same motion over and over. The person next to you is doing the same action Are you both going to get the same injury, or one person may get injured, the other person may not? Okay, you've seen that. Not everybody that does the same action, the same thing, is going to have the same challenges. And that's because of the structure, the blood supply and nerve supply. You alter that blood supply, nerve supply, or biomechanics, a person can be a checker all day long like this, moving groceries, everything else. Why? They have a beautiful curve in the neck. Somebody moving groceries like this all day long, they're going to blow out their shoulders, they're going to blow out their wrists. Okay, so there has to be a secondary factor contributing to the damage or the weakness of the structures involved. Does that make sense so far? Because there's always going to be a secondary thing, except the literature isn't supporting that it's a cervical spine problem, but they are supporting that it's a posture. Assessment of posture is an integral component of patient evaluation in shoulder overuse injuries. I would preface that and say it's not shoulder use injuries because you're supposed to use the shoulders. Okay, no one's, I mean, I look at this thing and it doesn't say, oh my God, don't use it longer than half a century. No. It's made by God. It's smart, okay? So when you look at this, what are some of the other factors? Using it too much with altered blood supply and nerve supply, yeah, there should be a warning label on it. Okay, however, professional literature contains relatively few studies that have asserted or have assessed the relationship between posture, function, and injury. Down to the highlighted portion there. Forward head posture was significantly greater in the patient group rather than the healthy group. Okay, so what they're doing, and they're looking at a number of different parameters, because remember, the people writing this stuff still think that this is a muscle problem. This is not a muscle problem. This is an adaptive physiologic response to a toxic deficient lifestyle. And movement, you got movement deficiency syndrome. By God, you've got that posture, okay? So these are people looking, and they found, what do we guess? Forward head posture. In people with overuse injuries? No. They had compromised blood supply and nerve supply, and they used their shoulder correctly. Okay, it's like driving around on a flat tire and saying, yeah, man, the steering doesn't work. Okay, now they almost get it. You're thinking, great, they got it. They found the forward head posture. We know that it's compromised blood supply and nerve supply. We know they got the thoracic outlet compromised. We know the brachial plexus is going to be compromised. I'm so excited. What's their conclusion? Regarding the influence of posture to shoulder injuries are inconclusive based on several confounding variables. Very confounding that may have affected the outcome. Because we're not looking at the loss of cervical curve or compromised nerve supply, we just don't know what's going on. Unbelievable. Okay, so now here's the Mayo Clinic. If anybody is a Naked Gun fan, the Mayo Clinic, see the jar of Mayo? Okay. According to the Mayo Clinic, shoulder impingement and weakness, and this is, diffused throughout the literature. Muscle tightness, weakness, or imbalances are associated with poor posture, can cause tendons in the rotator cuff to become irritated and cause pain and weakness. Already right now, this first sentence is wrong. The tendons don't become irritated, they become compromised blood supply. They can't produce that bursa fluid. Okay, and the joint capsule can't produce synovial fluid. So this is not a muscle imbalance. There's a structural misalignment causing compromised blood supply. That we know already. Forward hunched posture can cause these tendons to become pinched. The tendons don't become pinched. Okay, the head is forward. The tendons are already surrounded by a bursa sac. You can't pinch the tendons unless there's compromised structures. Eventually, this can lead to a tear in the rotator cuff tissue. More serious injury can cause significant pain and weakness and limit your ability to carry out daily activities. Absolutely. Then we go to the American Journal of Orthopedics. Factors associated with a failed rotator cuff. And so now I'm just like so excited. God, somebody else understands how to fix a shoulder. Factors. Poor quality tissue, poor blood supply, tendon atrophy, chronic tear, and degenerative changes. Great. Number one cause why rotator cuff surgeries fail is because poor blood supply. What do you think they're missing? Forward head carriage. Okay. Infection, of course, Gesundheit. Smoking, physiologic age, which is like ridiculous, okay, because I mean, the older you get, the stronger you get. Diabetes and non-steroidal anti-inflammatory use. Interesting. Now, why would non-steroidal anti-inflammatory use limit healing? Well, if we know that proteoglycans are the building block of cartilage, and we're looking at a fibrous cartilage thing called the labrum, and if we take an Advil, Motrin, Aleve, okay, a non-steroidal anti-inflammatory, that's limiting production of the freaking cartilage. Okay, so you're taking a drug, which is the most commonly prescribed drug around, and it destroys your body's ability to produce cartilage. Makes sense. I would see how that would be a factor. Okay, mechanical failure. Failure of fixation of the tendon to the interface. Second, failure of the fixation of the bone to anchor interface. Early aggressive rehabilitation. That makes sense. And this is what drives me crazy. When we're talking about stabilizing the shoulder, in fact, Stephanie, can I borrow you? Okay, one of the most important exercises, okay, is stabilization of the shoulder. Okay, and just turn and face me. The best exercise that we're going to go over is because in a shoulder injury, does that shoulder fall up or down? Up, because you got this massive deltoid. Okay, so now I have the 20-pound weight or the 5-pound weight. Which do you think is appropriate for? 5. Okay, and so when you're looking at this, if you have a big arm, you need a lot of force to pull it down. If you have a girl arm, you need a light force to pull it down. And so what she's going to do, she's going to turn her palms forward. Why? Because that rotates the head of that humerus in appropriate fashion. No, sideways is going to be better. Her chin's going to be up, so that restores the blood supply and nerve supply to the shoulder. And then she's going to just swing it butt to belly. So not too far forward. So butt to belly, butt to belly. Just like going a little bit too far forward. But, so it's just like, think of a pendulum on a clock. Because what's this doing? This is dropping that shoulder joint down in place. You're slowly reforming that labrum. And you're actually allowing more fluid to flow in there because you're having that joint move. Now what you'll see people do is they move it like this. Am I moving my shoulder? No. Okay. Was that my conscience? Yes, Lord. Okay, I'm abusing my worker. Sorry. You did good. Thank you. Okay. And again, the American Journal of Orthopedics, getting it. Persistent causes of shoulder pain following a rotator cuff problem. What's the number one cause? Cervical spine pathology and radiculopathy. Finally, we know that there's a problem with the neck. But remember, this is an orthopedic journal. Are they skilled in restoring natural curves of the body? No. If it doesn't involve a hammer, chisel, or a needle, it's not going to be done. Okay, suprascapular neuropathy. So we've got compromised nerve supply to the top of the scapular area. Remember the supraspinatus? That's at the top of the thing. So now we know, okay, so since it's at the top of the scapula, it's more vulnerable to compromised nerve supply or blood supply. This makes sense. Interarticular conditions, bicipital tendinosis, dislodged suture or anchor, okay, all of those are just mechanical problems. Persistent subacromial impingement. That makes sense, because think of this. Do they ever notice that that labrum is distorted superior, and instead of stretching out this, and I got to tell you, every patient with shoulder issues is here and they're saying, yeah, man, my doctor gave me these great stretches. I'm supposed to walk my fingers up the wall, and it really hurts. I'm going, no! Don't do it until we restore the curve in the neck. In fact, you're not going to be lifting your hand over your head for about 3 weeks. I'm going to have you just doing it. No, but I can almost get it up. No, wait. Okay, mellow out. I love this. Arthroscopic repair for chronic massive rotator cuff tears, systematic review. And it's interesting because if you're going to do the surgery on this, if you're going to do the rehab, but you're completely missing the compromised nerve supply and blood supply to the joint, do you think the surgery is going to be successful? Survey says? No. And you're right. The pooled re-tear rate was 79%. 79%. And you might say, yeah, but still it was 21% effective, man. I don't know, there's a positive stint on that. Okay, so bursitis, I want you to own this because if you have a chronic shoulder injury, moist heat penetrates, dry heat reflects. Moist heat on this shoulder area is going to increase synovial fluid production, bursa fluid production, fantastic. But what's the cause? This is just a parlor trick. Okay, just putting heat on there because you're tricking the body and an increase in blood pressure. The real cause is compromised blood supply. What's causing the compromised blood supply? Typically it's forward head carriage. But it could be unhealthy blood? Yeah, how many people are drinking enough water? How many people are taking multiple drugs? Average person today over 60 is taking 12 prescriptions. How healthy do you think their blood is? We just had a 17-year-old taking 9 prescriptions? Yeah, 9 prescriptions. Yeah, how healthy do you think her blood is? That's okay. She has diffuse joint pain. Man, we got some non-steroidal anti-inflammatories for her. I know, this is barbaric. Okay, calcific tendinitis. Now for one, tendons, okay, they're surrounded by a bursa sac and they're made of constantly regenerative materials. Calcific deposits, does that sound like healthy blood supply and nerve supply or altered? So, altered, and since we know bursa sacs are surrounding them, could that be chronic bursitis, chronic irritant of that joint? And what's it from? Subacromial impingement, okay, due to cuff dysfunction. That means that this has been a constantly jammed up structure because of long-term cervical problems in the neck, long-term compromised nerve supply. See, this is like, there's a big stream and they're looking down at the water here instead of the source. And that's typical with the medical community. They're totally missing the cervical component of this. Your body is constantly regenerating. If we compromise the blood supply or nerve supply, is the person that develops calcific tendinitis, do they have good digestion? Think of it. If you have chronic pain, I'm standing on your foot, you're in this fight or flight state. Are you going to be able to break down proteins to amino acids? Are you going to have healthy digestion? Are you going to have healthy sleep? No, everybody with shoulder injuries, they roll over and they wake up. They can't sleep good. This is miserable. You need your arms to work. Calcific tendinitis is not an acute injury. This is a chronic adaptive procedure that your body can't even make healthy tissue. Here's this one on the bottom left, pathology. The one next to that is normal, right? And you'll see a beautiful head of the humerus that's the normal one. See the one on the left there? You'll see that there's a huge distortion on that shoulder joint. This is a guy that's, I mean, and he comes in, built like a tank, okay? Hi, how'd you hurt your shoulders? Several explosions, Marine, Iraq, and our vehicle rolled over. I'm going, man, to have a real guy like this protecting our country, I'm freaking honored. And I don't want to piss him off. This guy is amazing, but all of his buddies, okay, that are in this, he's a bomb disposal squad in the Marines. So, I mean, just really, like there's tough and there's like uber tough, okay? And all his friends have had shoulder replacements. They can't lift their arms way over their head. They can't lift so many pounds. They can't lift anything. And when I'm going through doing the research, I can't find consistent data on restrictions for shoulder joints. Some of them say you can't lift more than 25 pounds. Others say, hey, look, you can do any activity you want. It's based on the skill of the surgeon or the type of the replacement. He just didn't want to risk that because he'd known several of his buddies that had that shoulder replacement. And they were not doing good. Within 2 months, he's able to lift his hands over his head. He has no pain. Interesting, though, we didn't fix the distortion at the base of that humeral head. So like from a doctor perspective, you're looking at it and you're saying, well, it kind of makes sense that it's good because it's in line with this coracoid process. I mean, if you measure it radiographically, it makes sense that it's a healthy joint now. Before it was like jammed up because, you know, the supraspinatus, of course, was just trashed. But he only got it better because we restored the curve in his neck and had him doing that arm thing. You restore the blood supply, you restore the nerve supply, you restore the mechanics, you alter that labrum, and the body gets better. Thoracic buckling. Okay, you've got all of these muscles that lock the scapula on that thoracic area. They move up and down. In fact, the shoulder joint only has one bony attachment that attaches it to the skeleton. Everything else is by muscles. So every time you move this, that scapula moves up and down. So if you have a distorted thoracic area, by gosh, you're going to get it. And you're looking at a patient there. This is her neck. You can see she has compromised nerve supply in the neck. But look at that huge thoracic rotation. And you might be saying, wow, that arm doesn't look normal. Yeah, I know, she had a shoulder replacement. Frustrating thing, did they fix the neck? No, they said, honey, you're gonna need the other shoulder replaced too. Okay, no, this is common because they don't know what causes it. However, if you look close, you're gonna see the other shoulder, the normal, natural one, there's no distortion of it. It's fine. She just had chronic shoulder pain. Why? Because of that thoracic distortion in the forward head carriage. They totally missed the actual cause. Complications with shoulder surgery, obviously pain. Now, this is huge because if you've had a shoulder operation, post-operative frozen shoulder, the most common challenge, okay, in dealing with a frozen shoulder, do you want to know what it is? You let it freeze. Then you restore because they say, oh no, I can't move it. So we got to keep breaking up those adhesions. And in fact, what they'll tell you is an exercise called continuous passive motion, where you're dangling it and moving it all the time to keep it mobile. If you're doing that exercise with compromised blood supply and nerve supply, you are not going to get it better. It's impossible. You're just irritating and inflaming a joint that's not in the right position. Once you restore the blood supply and nerve supply, and we'll get post x-rays on people's spines in 2.5 weeks, okay, after about 30, 35 adjustments, and we'll show that. Once that's restored, we know you've got blood supply and nerve supply to the joint. By gosh, we can break it up 2 visits. Then you'll have appropriate range of motion. Complications during surgery. I love the post-operative frozen shoulder. It's more common after rotator cuff repairs in older people. In most cases, it improves with physiotherapy, but sometimes a steroid injection will help it. Hydrodilation or surgery, which is manipulation under anesthesia. So they knock you out and then they break up the adhesions. Almost all stiffness is gone by 1 year after surgery. Yeah, or you fix the nerve supply, the blood supply, and it gets better. And this, when you're doing this exercise that Stephanie demonstrated so beautifully, realize you have to have sufficient weight to drop it down. But if your hands are internally rotated, if your head's forward, you're not doing it. Okay, you have to get the cause of it corrected. The cause of it corrected, and the cause is not overuse. Oh, good, yeah. This is actually a better picture. That's the Marine, the before. That's normal on the right. See that big old huge bone thing hanging down? You can see his before and after x-ray, where we're just now starting to get the curve back in his neck. And in fact, on the before, there's a little number up there, 38.61 millimeters. That's how far his head was forward. We reduced it down to 27. So reduced it a little bit less than 1/2 inch. But that started to get the blood supply and nerve supply working. We also decreased the thoracic curve. But you can see what a normal glenoid fossa and what a distorted one looks like. But he still had full range of motion. So even though there's pathology, and some surgeon, and I gotta tell you, this is common in surgeons, people come in here all the time, oh, it's bone on bone. Bone on bone. Yep. And I'll take an x-ray and I'll say, well, it's not. I can see a space there. It's not bone on bone. Okay, and people who bend their knees, I just had a patient from Arizona and said it's bone on bone. I said, okay, well, let's take a look. We took a picture. Was it bone on bone? Not even close. There was about a 1/4 inch gap there. And I think they might do it based on an MRI, which inflammation can distort the MRI, and typically MRIs are done laying down. So I guess they're doing erroneous information. But you know, standing weight-bearing x-ray, if you still see a space, it's not bone on bone. Oh, this is so cool. Okay, this gal, in 1979, she was run over by a car. She was missing her leg from up here. And I asked her permission, as she'd just passed about a year ago, if I could use her picture, because I had a blank thing over her face so no one can recognize her. She said, no, I want people to see me. And her big thing was she wanted to be able to lift her hands over her head, because I mean, you know, when you're missing a leg, you know, you can only have like, you know, crutches or a wheelchair. And, you know, from a wheelchair, it's hard to get stuff off the top counter. That's her about 90 days later. She's gone, but I still love the heck out of her. I mean, she's just sweet joy. But look at her neck. Her neck was reversed, you know, probably from that trauma that took her leg. And, you know, a near fusion like that, we were still able to get nerve supply and blood supply to it. Now, this is psychotic world. Remember, if you have a problem with the shoulder, is the neck involved? More than likely. How would you like to do so? And is that humerus jammed up or down in a normal position? So let's totally screw it up, okay? Let's jam it up, externally rotate, and then flex the head forward. Okay, you're watching me compromise my blood supply and nerve supply. Yes, let's stretch it out. Okay. Or you have the wheel of pain, not the one Conan was on, but you've got the wheel of pain where I doubt if they're working on the thoracic and the cervical spine, and they're just forcing it up in a good position. And yeah, you can demonstrate before and after movement, increased range of motion, you know, possibly decreased pain, but you're actually not helping the shoulder. This is a shout out to my youngest boy. That's my oldest surviving one. That's a dislocated shoulder there, and that's it replaced. Yeah, if you have somebody with a paintball injury, this is going to distort that labrum. It's going to distort the labrum. There are people that have had multiple dislocations. Danny had, I think, 4 of them. Okay, and then guess what stabilized the shoulder? Okay, that's it. And finally, he's, you know, like a shoemaker's family, never has shoes. Yeah, he's finally coming down to get adjusted, thank God. Okay, and we're looking here. Here's Maria. She came up from that, what's that? We can't decide if it's a continent or island. Oh, Australia. It's either a really big island or a really small continent. We don't know. Keep changing their mind. Okay, so you're looking at a beautiful restored curve and a horrible curve before. I mean, that's just neat to see the body work. So these are things to not do if you have a shoulder injury. No end range of motion. Not, it hurts here, but I'm just going to tough it out, force it, and get the whole range of motion. No end range of motion until you fix the actual problem, until the labrum is stabilized. No shoulder rehab without cervical and thoracic correction. If your body posture is like this, you will never get the shoulder better until you restore the cervical curve and have the labrum stable. Okay, I mean, it's kind of silly to do these exercises with a tourniquet on. You're not going to do it. If you have forward head carriage, you got a tourniquet going to the shoulder. It's never going to get better. You got to correct the forward head carriage before shoulder. No ice therapy on chronic shoulder injuries, only heat. Eliminate all the prescription drugs that reduce the body's ability to heal. Make sense? Yeah. I mean, you know, which ones make the shoulder better? Solutions for shoulders. You got to get a full x-ray series of the neck and thoracic area. once the cervical spine is restored, you can start the exercises, balance the labrum exercises with the cervical curve, because we'll get people, once we start getting their neck adjusted, within the second or third adjustment, we've got them doing the labral exercises. Proper nutrition and supplements, eliminate prescription drugs, get deep sleep, because that's when your body's going to heal. And once the labrum is stabilized, then you can start stretching it. And it typically takes about, I mean, on the Marine, we're talking it was about a month and a half before we had him doing full extension exercises. Anti-inflammatories, so if you're looking for an alternative to Motrin, fish oil is good, turmeric, blueberries, sweet potatoes, God, this looks good. Pineapple, papaya. Okay, you gotta optimize your gut flora, because the shoulder injuries, is it a problem of the shoulder, or is it a clue, a red flashing light, compromised blood supply and nerve supply? So you gotta look at the overall health. If you have a repetitive motion injury and the guy next to you doing the same job doesn't, do you think it's the job that's causing it? No, no. So when we look at this, we talk about organic plant-based diet, healthy fats such as coconut oil, unless you read USA Today, fermented veggies, probiotic supplements, juicing and blending, raw dairy, okay? And you can see, I mean, this is literally, when we put this up after each talk, appropriate nerve supply in a shoulder injury, absolutely. Exercise, proper nutrition, sufficient rest, and prayer and meditation. I'd invite you all on the cruise this year, except it's full. Who does that? No, think of this. I was thinking, I mean, 3 months, the entire ship is full. Who plans a vacation that far in advance? I did, because I'm organizing it, but it's just, wow. Yeah, I don't know if we're going to do one next year, but we're going to do one in 2019. So don't be like, you know, I'm getting some nasty mails like, you should have reserved more cabins. I'm sorry, I'll do better next time. And make sure you go to drjohnbergman.com. You're going to find articles, up-to-date articles, a disease database. I mean, this one, we're building and adding to it every week. It's really cool. Now, any questions?
Yeah,
Yes.
I ran across a kid today at the golf course, and he was a pitching prospect for Seattle Mariners, but he tore his labrum. He said, that's the end, that was the end of my career. Is it?
No. No, it is, unless they fix, if they got to fix the curve in the neck, they've got to stabilize that and reform the labrum. Reform the labrum. Because just like a cut skin, a cut labrum will heal. And in fact, that's what the surgery is. When they say, oh no, it's a Bankart lesion, it'll never heal. Yeah, because you try and stretch it all the time. You restore the blood supply and nerve supply. All they're doing with most of those labrum repairs is they're just approximating. They're just bringing the tissue closer together. And you can do that if you do that gentle, you know, dropping it down in place and applying pressure on it. Yeah. Yes, ma'am.
How do you calculate how much weight is necessary? You used
It totally depends on the size and strength of your body. You know, anywhere between 5 and 20 pounds is going to be appropriate. If you use too little because people are afraid, they're saying, oh, no, I just had surgery, or I'm going to go for surgery, or I'm really, okay, 1 to 2 pounds isn't going to do it. Okay, you have to have enough weight where it's dropping it down. And that's going to be dependent on the strength of the deltoid. So a chiropractor that's been working for 20 years, okay, 20 pounds is appropriate because it's going to drop it down a bit. But if I take 5 pounds, my arm's not even moving. If I take 20 pounds, I can feel it start to open up and separate. So you're going to literally feel it drop down and separate. Yeah, so 5 and 20 pounds. Yes, ma'am.
So if I have all those issues, do you know a good chiropractor I could go to?
Yeah. Well, I mean, the best one is use the 7 questions that we have to find a corrective chiropractor. If you find somebody that says yes to 5 of them, okay. Well, I know you're local, okay, but I'm talking about, you know, because we get people from everywhere, and a lot of people don't have the, you know, the means to travel around the world. Okay, so use the 7 questions. Somebody says yes to 5 of them, bam, you got a good guy. I mean, pretty much, if you have somebody that goes in there, identifies a lesion, does a certain therapy and takes an objective analysis that shows they actually fixed it, instead of saying, how do you feel? You know, I don't ask anyone how they feel. I should ask my wife, but I don't ask anyone.
So you could.
Yeah, you just got to get it fixed. Okay, next week we're talking about hips, how to regenerate hips, how to avoid hip surgery. And you'll see, it's going to be kind of fun. And the exercises to maintain your hip health.